Good evening, and thank you for joining us for tonight's update on fertility in primary care in partnership with Prince of Wales Private Hospital. My name is Bertha and I'm the CPD and Events Manager at CESFN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respects to elders past, present and emerging. I'd also extend that respect to any Aboriginal colleagues who may be joining us tonight. Just a couple of events that you may be interested on. These are all available on our website, but we run CPR training monthly, and there's a cybersecurity for your practice webinar coming up on the 29th of April, as well as a networking dinner for registrars and GP supervisors. And if you need any support from our practice support team, the details are on the slide, practicesupport@cesfn.com.au. And I would now like to hand over to Talia from the Prince of Wales Private Hospital. Thanks, Talia.
Thank you so much, Bertha. Good evening, everyone, and thank you for joining us. My name is Talia McKenzie, and I'm the Business Development Manager at Prince of Wales Private Hospital. I'd like to start by thanking the Central and Eastern Sydney Primary Health Network for the opportunity to partner with you for tonight's education session. Supporting GPs in our catchment is something we value deeply because we see the impact you make every day through early detection, timely referral, and the continuity of care. Prince of Wales Private Hospital is a leading tertiary facility specialising in acute surgical care and maternity services. We're also proud of our strong partnerships across the Randwick Hospital campus, supported by our co-location with the Prince of Wales Public Hospital, Sydney Children's and the Royal Hospital for Women. Over the last 12 months, 52 of our appointed gynaecological surgeons have treated just shy of 4,000 private patients. In fact, gynaecology is consistently our highest private patient admission specialty year on year. Just on to the next slide. Thank you, Bertha. With that, it is my pleasure to introduce our speaker for this evening, Dr. James Brown. Dr. Brown is a recently appointed gynaecologist at Prince of Wales Private Hospital with a special interest in menopause and fertility. On this slide, I have included Dr. Brown's consulting details and how to refer. Alongside Dr. Brown's work at Wiria, he is the clinical co-lead for the Specialist Menopause Service in Southwest Sydney and an active advocate in this space through both research and policy. Dr. Brown also provides fertility treatment, including IVF through Connect IVF. We're very fortunate to have him sharing his practical insights with us this evening. Please join me in welcoming Dr. James Brown. Thank you, James.
Thank you very much, Talia. Let me get my slides up on the screen. Beautiful. Cool. That looks like it's there. Wonderful. I'll get started. So thanks everyone for having me. I was hoping tonight to kind of dispel some of the complexity and difficulty around fertility, which seems to be this very large space that has competing priorities, both with you at the front line in primary care, but also the business side of IVF and the big commercial world that's become as well. So the purpose of today's talk is really to kind of simplify things so that if someone seeks or screens for fertility challenges in your practice, you kind of have a head start on knowing what to do, how to kind of interpret those things so that you can have that initial conversation, and then what the sort of treatment pathways might look like and how referrals get made. I'm super happy for questions as we go through, so feel free to pop them in and I'll try and answer them all at the end. Cool. So first thing you need to know is that this is pretty common. Although 85% of couples will conceive in their first 12 months of time trying, about 1 in 6 couples will be challenged by infertility during their life. But that prevalence increases of those who are actively trying themselves because of that 85% number, 15% are obviously challenged in that process while they're trying to get pregnant. The commonality of this problem doesn't make it any easier. It's a very emotionally charged problem, and you'll have lots of patients that you speak to who get really upset when they see their friends who they were hoping to sort of conceive alongside get pregnant while they lag behind. Fortunately, over the last decades, we've started to have a bunch of new options and investigations and treatments to kind of get to the bottom of different preventable and treatable causes, but also a pathway for those who haven't had a cause identified. And there's a lot of information about fertility in the media, often negative, about IVF clinics and what happens and the risks associated with it. And this can make things really confusing. I can imagine that if you're in primary care and you're advocating to send someone to a clinic of some kind, that you take a little bit of responsibility for how those things go. And so seeing that negative coverage might make you a little bit more sheepish to dip your toes in the water. So in terms of the prevalence, we spoke about that, but what the causes might be, it kind of is evenly split, which is quite surprising. So about 30 to 40% is female factor, 20 to 30% is male factor, and about 20 to 30% is a bit of both, and then 10 to 20% there's no cause identified. It's important to note, and this has become much more of a priority during infertility guidelines now, is that we really spent a lot of time looking at and analysing the woman as part of the fertility workup, but it's becoming increasingly important for us to make sure that we prioritise assessment of the male. Back when I was first starting, you'd get so excited with all the tests that you can order for the woman, assuming that the male is normal, and then after everything's corrected there, you were blindsided by the fact that the semen analysis was abnormal. So it's really important to assess the couple or the intended parents to be assessed in parallel at the same time to avoid that from happening, given how prevalent it may be. So tonight, to keep things really practical, I wanted to break it down just into these kind of categories that would move through the thinking and the clinical practice that you might see under the significant weight of primary practice, and hopefully give you a sense and to be equipped to have these discussions on the front lines as well. So to make this really basic, and this is actually how I speak to patients, is that when we're looking at fertility assistance, it feels like a big fishing expedition. But ultimately, there's only really 4 ingredients that you need to make a baby. And we're really just trying to identify that those 4 things, and the half, which we'll talk about as well, are not only present, but working in the way that we want them to be. So the most limited resource and the most important thing is the egg itself. Every month, a woman obviously ovulates. And so you've only got 1 egg per month, which means you've got a total of 12 chances total per year. It's kind of a miracle that anyone gets pregnant. So we want to make sure that someone is ovulating regularly and they can earn their kind of 12 tickets to the show every year. And so that isn't compromised by ovulation being inconsistent. The second, and like I mentioned before, one of the most important, is that the sperm is present. And it's not just a quantity issue when it comes to sperm. And in fact, you'll see in some future slides that nature is exceedingly forgiving of male semen. We're talking about 12 eggs a year. Your average semen sample might have 30 million sperm in it. And so there's a lot of reserve. Even if it's not quite perfect, there's still some sperm there. But what we don't fully appreciate is the prevalence of normal sperm is really, really low. So it may make a larger impact even though the numbers are quite significant. I'll walk you through interpretation of that later on, but it's important not to forget early on. And then we've got the uterus and the tubes is what's indicated by that picture there. You want to make sure that the uterus itself is a nice home for an embryo. Nothing's there blocking or scarred, and there's no irregular surfaces where an implantation may take place and not be successful. Equally, and quite obviously, having 1 or 2 patent tubes is important because the egg and the sperm will never meet if those tubes are not working. And so we do imaging, which we'll walk through, to make sure that anatomically everything's in place and normal in order to both get pregnant, but to stay pregnant once you've conceived. And the half that I'm talking about, and which has been in the news a lot recently, is endometriosis. It's not necessarily a fundamental ingredient of fertility, but it's really become encompassed and packaged as part of what we worry about with fertility. And if it's ignored, people can get quite upset if we haven't fully appreciated its contribution, which we'll talk through as well. So if they're the 4.5 ingredients that we're worried about, we're really just targeting our assessment for those 4.5 ingredients most broadly. And so even though it's common to not find a cause, we still want to investigate to make sure there's not a defect or a barrier, even partially, in any of those domains. So first, for ovulation, we want to make sure that the periods, and we'll talk about history in a second, we're going to talk a lot about periods, we're going to do some blood tests. For sperm, we're going to do a semen analysis, looking at key parameters, but also, which is emerging as something even more important, is optimizing male health, which we talk about a lot with women, but also need to talk about men. In some ways, it's more important in men. Semen in a sample only really reflects the last 72 hours to a week of their health. So any little gain that you can make will actually have an immediate benefit for fertility. The tubes and uterus, we're going to do some imaging. And for endometriosis, we'll talk about imaging and surgery. This approach, importantly, is generally similar between primary and secondary infertility. So I haven't really broken those up into two different causes or two different domains, basically because we cover much of the same stuff, whether we're investigating for primary or secondary infertility as part of this expedition. So the first question, if I was imagining myself in primary care and you're getting sort of undifferentiated people through the door, is when am I obliged to investigate? There's some people who are particularly anxious out there. There's also people who are very proactive and planning around their fertility. I get them a lot too. People who come in with no intention of getting pregnant in the next year or two, but want to know what would happen if there was to be a problem, even though 85% chance everything would be totally fine. So here are some really basic guides on when you could kind of classify infertility or subfertility as worthy or reasonable of investigating, meaning that their chances of success is diminished to such a point. For those under 35, we would normally classify that as after 12 months of regular unprotected intercourse. And for those 35 and above, we would say after 6 months. I think that's probably a little bit conservative, and we'll talk about it on the basis of a graph, but it's just a nice round number that we tend to use. There's also a recommendation that you may want to consider immediate investigation if there's a known specific risk factor that may impair their fertility. And so if you can reverse that early on, you're increasing their chances and decreasing the amount of time that they would have to try for. The most obvious would be if their periods are either irregular or absent. There's really no point trying for 12 months if you're only having 3 periods during that time, because you've only got 3 chances of that year, and it's really hard to time intercourse to compensate for that. Same thing for endometriosis. If someone's coming in and they've got a pretty severe history of endometriosis, that's important to probably consider before they embark on trying itself. The reason why they include surgery and pelvic infection is that those are risk factors for tubal disease, blockages on both sides. And so if the tubes are blocked and you have a pretty reasonable concern, it might be worth checking that up front even before someone's tried. And then, of course, things like male factor risk, undescended testes in the past, or chemotherapy. Or more commonly, a lot of men are on anabolic steroids for the gym. And so it takes a long time to restore that pituitary axis. And so knowing that sooner, before they're trying, is always going to be a lot more valuable. But that's usually the basic parameters for when you can say, look, this is where there's value in investigating. This is a graph that I show a lot, and I know it's kind of scary for a lot of people, but I actually think it's broadly optimistic. This is just showing you broadly what the monthly pregnancy chance is for a lady who's ovulating normally, who doesn't have any necessary risk factors or disturbances, and the sperm is normal. So what you can see here is that basically under the age of 30, the chance of pregnancy per month is about 20%, so 1 in 5. That's not too bad, given that especially we start to talk about early to mid-30s is this kind of doom period where your fertility is declining. If you follow that graph into the yellow bars in the middle, yes, there's a progressive decline year on year, but you're losing about 1 to 2% chance of that monthly chance year on year as it declines. So by the time you get to 35, it's still above 35, sorry, you're still above 15%, which is not far different from the 20-ish% that you had 5 years earlier. But as you can see, the reason why we talk about over 35 as the reason when you may want to, curtail how long they try for is that it starts to dip below 15% per month. What you'll notice is the curve kind of changes shape around 38. There's that big step down, and that's when the curve kind of concaves and it starts to accelerate in a decline, going from a gentle curve down to a more accelerated one. And as you start to get into your 40s, you're really losing almost 25 to 30% of your pregnancy chance, relatively speaking, month on month that you miss out. And so trying to get pregnant earlier obviously has some value. I use this graph a lot, mostly to reassure people that if they're not ready for this, or if they want to try for 12 months like we've recommended, they're really only losing 1 to 2% of their monthly chance if everything else is normal and there's no risk factors. So I often use this as the framework to discuss it. But just to let you guys know why there's that kind of voodoo that happens around 38. Once you've got an assessment that you think this person wants to talk about fertility, I don't need to tell you guys how to take a history, so I'm not going to. But these are some really specific questions that I try to ask because they're really high yield. If you can get good answers to this, it really starts to push you down the railroad of the different suspicions of those 4.5 ingredients that I mentioned before. First and foremost, we talk so much about periods. Periods, as you know, are intimately linked with ovulation. If you don't ovulate, you don't get a period. If you're not getting regular periods, you're not regularly ovulating. And remember, the egg is the most precious resource. So knowing that cycle is really just gold. Second domain would be endometriosis symptoms. You don't want to be someone who kind of misses that, especially with all of the social media and awareness out in the community around endometriosis. Often people will come with their own suspicions already. STI history for blockage, infection, and adhesion. Obstetric history to make sure that they've either been pregnant before or not. It's not very scientific, but if someone's with the same partner and they've gotten pregnant before, that's actually a really positive prognostic factor. There's some secret source that they can get pregnant in the past naturally, really bodes well that they're going to be able to get pregnant again, unless there's been some dramatic change. Weight, exercise, and eating patterns are also really important. Often because the people who seek us for fertility treatment are obviously a bit more socioeconomic advantage. They're often people who are corporate and have delayed their fertility. They're often very fit and they often really care about their diet. And sometimes that's to their detriment. You'll often see women who are appearing to be extremely healthy, but their periods are very irregular. And that's basically because they're in that starvation state of hypogonadotrophic hypogonadism, where the brain has kind of shut down the ovarian signals. And the hard part is restoring that is often just by letting them get a bit more relaxed on their routines, which we'll talk about shortly. Endocrine symptoms, particularly androgenic symptoms, such as hair growth, acne, deepening of the voice, because they can interrupt ovulation and would be associated with PCOS. And then, of course, the medications and supplements that people are taking. I struggle to keep up with all the different supplements and medications people take, including the recent sort of enthusiasm for peptides from overseas as well, which again, I can't keep up with, but hear about a lot. So they're the basic questions for the female. The other questions for the male, and remember, we're seeing them usually in conjunction at the same appointment. You may not need to do that, but if you have the opportunity to, here are some guide questions to ask as well. And it's not much more beyond this. First is, has the male parented any other children in a separate relationship? That kind of tells you that, his bits might be working. If and how he went through puberty to make sure that there's no primary hypogonadism that might be a problem. His sexual function. We often don't ask this, but if he's unable to ejaculate or if he's unable to get erect, it's really hard for them to get pregnant naturally. Equally, anything that may have damaged the testes, that could either be trauma, surgery, or something like chemotherapy. There's a lot of environmental concerns. Remember that I mentioned that the sperm kind of turns over every 72 hours. So it really internalizes whatever's been going on in that man's life at that time. There's a really big emerging enthusiasm for plastics, which I won't talk about tonight, but things like heat, excess heat, cycling would be another one, exposure to chemicals as part of their occupation. To asking those questions often provides you clues and makes you feel really clever. And like I mentioned before, drugs such as anabolic steroids and peptides are really important. There's a mention in the questions here about varicoceles. Exactly right. So any masses or abnormalities of the testes would be an important question to ask. And if you're concerned, to do an examination. And then once you've got them together, and it may seem self-evident, the other question to ask, both of them, is how and when have they been trying? It seems self-evident. Some people haven't had the most expansive sexual education. So asking them throughout the cycle when they're timing it, how they're tracking ovulation, how they're having sex, it sounds foolish, but how often they're having sex during that time are all really important because you'd be really surprised at some of the fixed beliefs that people have. For example, I had a couple who'd been trying for quite a while and they had read somewhere that the optimal ovulation date was day 10 of the cycle. What she'd kind of discounted was that her cycles are about 31 days long. And so she'd really been anticipating what would normally be the ovulatory window for a lady with a shorter cycle, but was really just shooting the bolt too soon before her actual ovulation would be taking place. So asking all these questions, asking how they've been tracking, whether it's with an app, whether it's with LH kits from the supermarket, all of that's really important. And digging down into that. Often you can solve a lot of problems just by doing that. And we'll talk about management of like normal pregnancy trying later on in the presentation. So you've taken your history, you may have chosen to do an examination if you're looking for things like a varicocele, but now we're moving on to what's kind of the bread and butter, which is the type of investigations you would do as an initial investigation. I've tried to break these down back to that 4.5 kind of ingredients, just so we have a framework of why we know why we're doing things, because it kind of helps recall rather than just fishing out there. It also helps you kind of pay more attention to where you think the concerns are based on the history. So, first concern, is she ovulating or not? If the periods are irregular or spaced out or concerned, the way to confirm ovulation most reliably is around a day 21 progesterone level by blood. We would normally aim for a value of 25 nanomoles and above. But if she has regular periods and has pretty reliable symptoms of ovulation, breast tenderness, abdominal pain, discharge, you can really probably forego this element because the periods are pretty reliable in that scenario. If she has irregular periods, you kind of do what you would normally do for an oligomenorrhea screen. First one would be testing her gonadotropins, the FSH and the LH, and then also doing her estradiol and testosterone levels. The purpose of this, and we'll talk about the interpretation shortly, is to kind of get a sense of why the pituitary axis is not working the way that it should. Other tests you may include is TFTs and a fasting blood sugar or HbA1c if you're worried about PCOS, prolactin, a HCG if you don't want to get caught out because they are trying for pregnancy, and if there's concerns around PCOS, you do a 21-hydroxyprogesterone. That would be your kind of standard oligomenorrhea screen for women who have a secondary, so have had normal periods before or periods that have always been somewhat irregular rather than entirely absent, which is a different problem altogether. Moving on, if we want to interpret it. So the way I formatted this section with the assessment, I was racking my brain how to do it. I decided on doing the assessment basically and the interpretation one by one next to each other, just so we can keep the memory of why we're doing things. So if you've done this test and the day 21 progesterone is negative, meaning that it's less than 25 or not elevated at all, you can basically confirm that she's not ovulating regularly. And the frequency of her not ovulating will typically be guided by how many periods she's having. Then, if you have done the other tests to get a sense of why she might not be ovulating, the gonadotropins and the estradiol really keeps you from making too many mistakes. So I know you guys already know this, but I've got to say it. So if the FSH is really high and the estradiol is low, that's suggesting that the ovary does not have the capacity to respond to the stimulation from the pituitary gland, and that would suggest something like perimenopause or menopause. In contrast, if the FSH is very low and the estrogen is very, very low, that's indicating that the pituitary gland is not sending signals to the ovary, and therefore the ovary can't respond. That is your classic hypogonadotrophic hypogonadism, which is typical of people who are exercising, restrictive diets, people under chronic stress and have chronic disease. They're really hard to treat, but it does help you kind of divide up what you're trying to achieve. And then, of course, if both of those are normal, the most common cause would be something like PCOS, if it fits the other criteria, and you'd want to spend a bit more time thinking about the thyroid, prolactin, and the other things that we checked. So that's how you do those tests, and that's how you'd helpfully kind of interpret those to explain to the patient when you speak to them. Moving on. The next kind of tricky question is, are there enough eggs? So yes, she's ovulating, but we need to kind of count how many there are, but it's a very fraught area, this type of counselling. The test that you're almost obliged to order is the AMH blood test. That is reflective of ovarian reserve. So I don't want to turn this into an AMH talk, but just remember, it's reflective of how many follicles are in the monthly race to try and ovulate. Now, if someone has regular cycles, whether or not there's 5, 15, or 50 follicles all fighting it out, they still just lead to one follicle. So having a low AMH that's not extremely low, but having normal periods doesn't really reflect impaired pregnancy chance, meaning you just have a smaller race, but you're still regularly ovulating. What AMH does do is it helps you get a sense of the likely success of different fertility treatments and certainly guides the type of dosage that we would do. You can also get an appreciation of the follicles by doing an ultrasound, which we'll talk about in a bit more detail in a future slide. There's a question here around the FSH to LH ratio mattering. Unfortunately, it doesn't. We use pretty block terms, so no need to get too technical about the ratio itself in most practice. So interpreting the AMH, I wanted to help you here because I always get caught up with this. If it's high, they're likely to have PCOS. It's not a diagnostic feature, even though that's a complex discussion. And the reason why you do this is to kind of caution them if they were to ever do IVF, they would be at a higher risk of ovarian hyperstimulation syndrome. If the AMH is low, and most of the time it is below average, it only supports perimenopause or menopause if the periods have changed as well, meaning they've started to space out and there's been hypoestrogenic symptoms as well. But as I mentioned before, its primary utility is in assessing treatment response, but you've got to kind of do it. The other thing is you already know this costs money, the other blood tests don't. It's about $90 at the moment, I think. Moving on. So we've talked about eggs. Now we're talking about the uterus and the tubes. The classic test that someone would order is a hycosi. So that is basically a contrast ultrasound that would typically be performed between day 5 and 10 of a cycle. In terms of where and how to perform this, some tricks that I've made mistakes with in the past. Normally this is done at a women's imaging location. You'd normally ask them to call on the first day of their period because it often has some lag time in order for them to be booked in. Let them know that it's pretty uncomfortable. So most people would appreciate pre-treatment with Panadol and or Nurofen because ultimately what's happening is their cervix is being cannulated and fluid is being pushed through the tubes and then it's spilling into the abdomen. The benefit of this test, because it shows the negative space, as you can see by that white contrast in the middle of the uterus, is not only that it identifies the tubes, which are labeled there, but any lumps or bumps or fibroids or septum that would be filled in that negative space. It's also helpful to identify scarring, like Asherman syndrome. Most of the time, this can be done in conjunction with an antral follicle count and a basic ultrasound. And if you are suspecting endometriosis on a strong history, it's best to get all of it done at once. And so you can ask for a hycosi and DIE scan and antral follicle count all in the one and done. Or get it all done so that you have this one piece of information rather than sending them back for what can be pretty invasive tests. There's a question here asking if it's worthwhile to repeat AMH if it's low or is it constant. Generally, there's no point because of how broad its benefit is, meaning just dosage-wise, it's worth not really repeating it because you've got the vague information that you need. Is it broadly normal? Is it broadly low? Is it broadly high? Adding, it won't go up so dramatically such that they'll move out of one of those categories usually in a short time frame. So as I said, how you diagnose, you're really looking for polyps, septums, fibroids, and scarring, which will be on the report, as well as looking for non-patent tubes. But I do have to warn you that there's often a false negative is what I should say. Actually, it's a false positive. Either way, you may have a false result that says the tubes are not patent, but they may be patent on another day or as part of a laparoscopy. So let them know that this is demonstrating tubal lack of patency, but it is a variable finding sometimes. Any guide about how high an AMH would be suspicious of PCOS? It's usually it depends on age because there's different centiles, but off the top of my head, it's just above the 10th centile. If you see ladies with PCOS, often it'll be, I don't think I've seen someone without PCOS with a level above 40 or 50 off the top of my head. Good question here asking, do GP need to organise a hycosi or just refer for specialists? Really good question. I think it depends on your comfort level and your experience with doing this. I can imagine I'm in this position a lot as well. I really hate when I refer to someone else and I'm always nervous that I've done the right test. In most cases, though, if you've done a hycosi and you've done an ultrasound at the same time, no one's going to get upset, and it's usually an essential step of things next. So if you think with conviction that it's the right thing to do, please feel empowered to do it. No one's going to get bothered. But also, if you don't feel comfortable, if you're not sure, there's no urgency. It's a standard part of fertility practice. So don't worry. Either way is pretty normal. Next part, and what's a big discussion, is talking about the semen analysis. So like I mentioned before, we kind of underestimate the contribution of the sperm, even though it's 50% of the picture. And we may not even order it because often it's the woman who's come for the consultation, not the boy. But it's really important that you order a semen analysis. And there's a bit of nuance to how and when you order it. So first thing, you can order quite a cheap semen analysis from a usual pathology provider. it's not as good quality, and often we're making really big decisions on this. So if people have the financial means of doing this, and you have the capacity to do so, it might be worth getting them sent to one of the many fertility clinics that have an andrology lab on site. Most of them allow for online bookings, so the patient can just lock in or go. And what ends up happening is that they're advised to abstain from ejaculation for 2 to 3 days beforehand. So they're going to want to time it outside of their natural conception window, just so they can save up the juice. And what you also need to warn them is that it does get collected on site. It's really uncomfortable, can be a bit awkward, but it's really important because even a small delay, more than 20 minutes, depending on how the temperature's been or what they've been doing, can really ruin results. So I remember a case where we had a big discussion about this gentleman who had basically no sperm left, and we told this whole story and then kind of thought to ourselves, well, maybe we would repeat it again. And then we repeated it at our lab, and it was like we had to check the name because it was a completely different semen analysis. So we looked back and we kind of asked him what happened differently, and he was surprised that this time he had to deliver on site, basically, donate on site. And we asked him what he did last time, which was do it at home, put it in a jar, and then ride his motorcycle to the laboratory. So whilst it seems convenient to do it at home, obviously, doing it on site gives you much more accurate results, and it's basically interpreted instantaneously at an andrology lab. What is the arrangement? There's a question here asking, what is the arrangement if sperm analysis done from outside pathology? Not a problem. If you've done it as an outside pathology and it's abnormal, in general practice, I probably wouldn't repeat it. I'd probably just send on to fertility because we'd still need to do investigations for low sperm count. So don't make them repeat it on your count or like because of you, but I would just warn them that they may need to do it again once they see the specialist. There's a question here saying that it's been reported that sperm counts have decreased in the last 10 to 20 years as a result of epigenetic factors. It's true, it is, and we're trying to work out why. So again, we're not sure why, but we are picking up more abnormal results. Good question here regarding the day 21 progesterone test. So if the cycle is longer, then in theory, you can push it back to day 25. For those who don't know, you might already know, the only fixed interval of the cycle, if it's variable, is the day between ovulation and the period. So you just work backwards from when you think the ovulation would be from the period itself. That's basically always 14 days. Question here, does Women's Hospital provide semen analysis and is it reliable? The answer is yes and yes. So I believe it's through SEALS, and I routinely refer there and get it done, and it's quite affordable. So referring to SEALS at the Royal Hospital for Women is an excellent place to get a semen analysis done. Perfect. Good. Perfect. They covered. Great. So we'll keep moving. So now the hard part's the interpretation. So when you get the result, it won't look like this. It'll have maybe 3 or 4 times more numbers on it. And it's really hard to kind of piece out what is important information. Here's the cheat sheet. All we really look at is volume, concentration, progressive motility, and normal forms, acknowledging that this is just showing a window from the last few days. Volume is the total amount of semen produced. That's important to work out if there's an obstruction at some part in the channel. If there's no volume or low volume, then clearly something's going wrong. The next most important part is the sperm concentration. So that's how many sperm there are per milliliter of semen. Generally speaking, 15 million is the right amount. And that's what then leads to the total sperm count being above 40 million. So if you look at that math, 15 million per mil times 1.5 mil volume is basically leading you to close to 39 million per delivery as such per sample. But volume and concentration are only so important unless the quality is also good. Here we look at progressive motility, so how many are fast swimmers, and we like that to be above 32%. And what I'm always constantly blown away by, which actually there is under morphology, is that we accept 4% only or more as actually being normal. So as you can imagine, even though there's millions and millions of sperm, we're already down to only 4% theoretically being normal. So that's why diminishing numbers are really important to consider. But these are the general guides. In most cases, just as a practical tip, we only really care about the 0. because that means they can't produce it. It's entirely blocked. And from 0, we can't do much. At lower levels, after being investigated, we usually can do fertility treatment. So when you're talking to someone, even if it's not a perfect sperm sample, reassuring them that there's some there at a decent quality is probably enough for them to become pregnant, either naturally, but more commonly IVF. It's more that 0 that we really want to refer quickly and do further investigations, just to let you know. Cool. In terms of a copy of the slides, yeah, of course, no dramas, mate. Easy. Further assessments. So this is just to cover your bum, so I can cover my bum. 2 things to mention. You already know this, you do this all the time, but I'm obliged to let you know. It's routine practice for anyone considering fertility to be advised that there's bulk build 3-panel recessive carrier screening. You don't have to force it upon them. It's still very optional, but you're just obliged to let them know and document that you have. We also often do karyotypes. You may choose not to, and that's fine. The reason being is it comes in handy in the future for different investigations, but depending on the laboratory, it can be very, very slow. At the moment, I haven't updated this for a while, but my understanding is that Douglas is very fast at turning around karyotypes, but charges a lot for them, whereas other places are very slow, but it's bulk built. So often doing this upfront, meaning you only have to do it once because the karyotype doesn't change, means that you've kind of got it in the bank and you don't have to worry about missing it in future. Cool. Just as you already know, if either of these are abnormal, you go to genetic counselling, easy peasy. Cool. All right. So you've done your assessment, you've got an idea of what might be going on because we've broken it down into those 4.5 domains. So these really, and I write this out for patients every time. These are our 5 menu items that we can pick from for fertility treatment. That's all it is. This is the whole universe. First one is do nothing, but optimize where you can. The second is ovulation induction. This is usually most appropriate when periods are irregular, but everything else is normal. Endometriosis surgery, which we'll talk about. We'll talk about all of these. Intrauterine insemination, and then we'll go through IVF just so you have a sense of what goes on. Cool. First, I'm obliged to let you know that this junction of high motivation, wanting to get pregnant, is an ideal time for people who might have been busy and a bit neglectful of their health to kind of pay more attention to it. So talking about healthy weight, regular exercise, balanced diet, stress, all that other things, all really important and probably contribute quite a bit. There's a question here around Menopause improving sperm quality. I think if it does, it would be in a small way, subtle. Remembering that it's really, we've got a fairly generous normal range, so even a small improvement won't make a huge difference, but Menopause doesn't hurt and is highly recommended now as a multivitamin. And as mentioned before, very happy to share the slides. Cool. So it seems strange. Someone's come to you with fertility problems and you say, well, what if you just did nothing and just kept on going? This is obviously only good for people if everything else is normal, especially if they're young. So as we saw from that graph, if someone's say 27 or 28 and they've been trying for 9 months, there's a really good chance over the next 3, 4, 5 months with a normal investigation that they will be able to get pregnant. The education in this process is the most important part. So what I often talk about is the age-related pregnancy decline. I'm not scared of too much, but I am scared that maybe I have a too casual a conversation and I go, yeah, you can wait, it'll be fine. And then they come back when they're 38, 39, having to really internalize that and now finding a real struggle and saying, well, hang on, you didn't tell me my fertility would have dropped by 30 or 40%. So I show them that graph not to scare them, but just to say this is realistically the timeline that you're working on. Another thing to offer is that most people will do ovulation tracking with either basal body temperature apps, most commonly these days, ovulation kits that just test the LH surge from the supermarket. But most fertility clinics, whichever one you choose, now offer bulk build or free ovulation tracking. So I don't care which place you go to because it's all the same. But ultimately what these ladies get for free is usually 3 cycles off the top of my head of basically what we would do to check a cycle that we were going to put an embryo in. So they get some blood tests, telling them and watching them as that estrogen rises. As soon as the LH surge occurs, the nurse calls them, say, hey, you know, red wine, foot massage, whatever, do what you got to do. And then they'll also often get the day 21 progesterone. So it's a really good free service that a lot of the clinics provide. to really give people visibility and certainty over their trying, particularly for those patients who may not be as health literate, because they do get a little bit of hand-holding by the expert nursing staff. The other thing I talk about, and I'm going to talk about the next slide, is intercourse strategy. It's surprising how few people kind of got the right idea, even though it's pretty general. We already spoke about general lifestyle advice. We want to talk about, hey, if it hasn't happened by X, by a certain day or year or whatever, then I would escalate. And then, of course, educate them on supplementation. Another question is how common is mumps as a cause for low sperm count these days? Extremely common. I think I've seen it once in someone who was born in Australia. For someone to be referred for ovulation tracking, they do not need to be under a specialist. You can refer yourself, and most clinics will have online, or if you request it, an ovulation tracking kit, like a little referral document. All that will happen is at the end of that, the ovulation tracking, you'll be sent a report. But if at any point the ovulation tracking is abnormal, then that will be automatically triggered to kind of alert a specialist to kind of get involved. So it's actually a really nice system for you. Commercial ovulation kits are indeed reliable, but you've got to use them right, which I'll show you now. Cool. So I live my life looking at this graph, but what I want to show you is that when you're using an LH kit, which is what the supermarket ovulation kits are doing, they're really just looking for this elevated LH surge. Okay? And so when we talk about strategy for conception, it's really basic. On the day of the LH surge, probably an ideal time to have intercourse. I'd say have a day off to rehydrate and then get back on it. And then you can get back on it again if you really feel like it. But ultimately, it's basically episodes of intercourse on the 4 days following LH surge. There's a logic to this. The egg lasts for about 24 hours. The sperm lasts for about 48 to 72 hours. So if you can have sex twice across 4 days, you've got all this, basically this sperm laying around whenever that precious egg comes along. The problem when you tell people this stuff is it gets really prescriptive because they'll be like, we do it today, and we're stressed out from work, whatever. Next day, hands off. And it really messes with their kind of psyche and the intimacy of the relationship. So even though we give this guidance, I often say, look, there's some fudge factor to this. As long as you squeeze in 2 times over the 4-ish days, you're doing everything you can to earn your percentage. The other thing I say is really try and preserve sexual intimacy as spontaneous sexual intimacy on every other day. Because even the most lustful people, and I remember lots of them, basically get burnt out by this process, and it can cause some pretty significant long-term resistance within the relationship. And remember, we're asking them to do this for a year. So this can be really full on. So asking them to pace themselves, expect that there's going to be an error factor, and also trying to maintain and prioritize intimacy outside that window is really important. The other thing is that often people say, well, I want my husband to kind of save things up for the whole month so that he's ready for the LH surge. It doesn't quite work like that because the sperm turnover is every 3 days. Cool. So that's the do nothing approach. Pretty reasonable, suitable for some. Second approach, ovulation induction. So ovulation induction is a simple process of enhancing the probability of ovulation. This is good for women who have irregular cycles, but is less effective than with women who have hypo, like I mentioned before, because it really just boosts or augments the pituitary signals. So if there are no pituitary signals, then it doesn't work as well. The process is simple, and as a general practitioner, you wouldn't be expected to do this and monitor this because it can be quite tricky. But basically, we give 5 tablets, so 1 tablet a day from day 2 to 6 of the cycle of basically the aromatase inhibitor letrozole. We start at 2.5 on that first cycle of 5 days and move up if we haven't fully achieved ovulation. People have previously used clomiphene and metformin, but letrozole is standard practice because it has a lower multiple pregnancy rate. If you have someone who started on this, we will have always told them there's a higher risk of multiple pregnancy, around 1-ish%. And it's really important that all the other investigations are normal. There's no point fixing someone's cycle if the tubes aren't open. There's no point fixing someone's cycle if the sperm's no good. So this is particularly good when you've isolated a single problem as a subtle ovulation defect. People usually do this now as what we call a monitored cycle. meaning that this will be initiated, much like the ovulation tracking, by an IVF clinic, where they'll be told about the medications, get their blood tests done, tracked appropriately, and then told when sex strikes, basically. You can theoretically do it unmonitored, but that would put you at a slightly higher risk of multiple pregnancy. When they're doing it through a clinic, we often do an ultrasound. And if someone hasn't ovulated for a while, they often ovulate 2 follicles, sometimes 3. And if they ovulate 2 big follicles, or we can see 2 growing, we tell them, hey, look, you can roll the dice if you want to, but if there's a chance of twins. If there's 3, and each of those 3 have your age-related pregnancy chance, so it could be 25%, we say separate bedrooms, cold showers, avoid at all costs. If you commit to this, you need to use it for a minimum of 6 months to really get the max juice out of it. Endometriosis, formal data, I don't think it's been updated recently, shows that resection of endometriosis, I think it's mild mostly, may improve natural pregnancy chances, but it's contentious whether it improves IVF. There are 2 theories of fertility impact. One is anatomical distortion, and the second is local inflammation at the site of ovulation. That's why removal of small amount may improve, as well as removing some large amount also. This is good for people who have a proven, either on imaging or high clinical suspicion of endometriosis, and certainly no other barriers to natural conception. Because really the practice is that you do the resection, which, there's a lot of bad press around endometriosis. You really just want to do that surgery once as well as you can, and make sure you maximize the next 6 months. So there's no reason doing it if they're not actively trying and they're just trying to sort of prevent it for the future. And it's important to note that if you do the surgery, they're then going to cycle for 6 months. So you do run the small risk of recurrence without the suppression. But you'd ideally have this as a one and done rather than doing it over and over again. Cool. I won't spend much time on intrauterine insemination, but it's basically where we concentrate the sperm and time the insemination. So we basically just do ovulation tracking. And then when the LH surge happens, rather than doing, having sex the old-fashioned way, they ruin the romance by coming into us. The partner provides a sample, it gets spun down into a concentrate, and then we basically squirt it inside the uterus. This is good for people who are unable to have penetrative intercourse, people who are using frozen sperm, same-sex couples who are using donor sperm. Usually done naturally, meaning without medication through an IVF clinic. And importantly, it has broadly the same pregnancy rate, if everything's working normally, as if you had sex on the same day. The way I explain it is that I'm no better at putting the sperm in there than anyone else. It's in there, it does its thing. You're really just alley-ooping it through the cervix. That's all you're really doing. I would argue that this is pretty narrow to who it benefits. And it's important to note that that kind of concentration of the sperm doesn't really improve the low-quality sperm in any selective way. Really good question here. Someone asked about whether hycosi increases the chance of conception if it clears the small blockages. And the truth is it does. I didn't want to get too technical, but we use just a general saline wash, and there's a thing called lapiodol, which is more viscous. And so you do have a very small and brief improvement in your pregnancy chances after a hycosi. But I wouldn't use that as a therapeutic, but it's a nice thing to counsel someone. Now let's go through IVF. So the reason why I left this to the end, it's sort of a question that I always feel like patients want to ask, which is like, why does it seem like everyone gets IVF? And I always go through that menu first, even if they kind of only have the choice of IVF for this reason. Because the truth is IVF fixes most of the problems that we already can't fix. It provides cycle control for women who can't ovulate because you have complete control over the cycle. If they have a low egg count, we can stimulate the ovaries. If the tubes are blocked, we bypass that process altogether. And if the sperm is low or poor quality, we can actually pick out individual sperm and put them into eggs. So ultimately, it kind of is the best of all worlds. And so even though there's kind of, a commercial impulse to be doing IVF, it's because it does a lot more jobs than the other stuff, which can be quite narrow. But at every stage along the spectrum of preconception, it allows the opportunity for analysis and intervention. So it's all very visible. Cool. So I won't try and spend too much time on this because we're running out of time. But basically, if someone's planning for this, you refer them to an IVF clinic, don't care which one it is, and they will arrange some basic blood tests. The process will be explained and consented. Based on the numbers and the age and their BMI, a treatment plan will be submitted to the IVF clinic, and then a nurse from that clinic will contact the patient for what we call an orientation appointment. This will be how to start the meds, where to get the medications, and then throughout the cycle, the day-to-day results, which we'll talk about shortly, will be communicated to the patient via the nurse after being discussed or reviewed by the IVF specialist typically. So I'm going to do this quite quickly just because it's probably a bit beyond the scope of tonight, but I just wanted you to know what happens during IVF so you feel a little bit familiar with what's going on. Ultimately, what happens is a woman will come in on the first day of her period and she will start the first medication, an injection that's daily, which has the hormone FSH in it at a much higher dose than nature. She'll then come in for a blood test on day 4 of the cycle or day 5, and that's when they often get a second medication started. Now, the first one is stimulating the ovaries. The second medication is blocking the signals from the brain. It's a GnRH antagonist. What that means is that we can push the ovary well past the normal signal for ovulation when LH would come down, which means we can try and grow as many of those month's follicles into a zone where we think they're mature. From day 8 onwards, you're getting second daily blood tests and ultrasounds through the clinic of your choice. And then the follicles we're measuring one by one to get their measurements. The sweet spot for a follicle is between 14 and 20 millimeters. They're always moving ahead. So you don't want to lose the good ones out the front and tip over the edge. And you don't want to call it too soon because you haven't really maximized the group. It looks like this on an ultrasound, big follicles. Once most of them are in that zone, that frame, we end the cycle by giving the trigger injection, which is basically just artificial LH in most cases. And then the patient comes in exactly 36 hours later for an egg collection, exactly 36 hours later. They go to sleep, ultrasound probe, remove all those fluids that I showed from here, and the embryologist at the same time is counting those eggs. The mature eggs go back to the laboratory. The partner, in another spate of injustice, donates the old-fashioned way at the same time, and then we reunite the egg and the sperm in the lab. IVF is when you put a little bit of sperm and an egg in each well, and they fight it out with natural selection. And ICSI is what you'll see on TV, which is where you get the egg itself and you watch someone push a sperm right in directly. So imagine if you've got low sperm count and we only find like 20 sperm. That's fine if they're okay because you can push one by one into an egg. And that's how sperm is handled and selected as part of this process in a very simple way. Once it's fertilized, they grow for 5 days in the incubator, going from 2-cell stage, 4 cells, and growing all the way to a blastocyst. This is an uncertain process. Not all of them will make it. And then by day 5, they come in for the embryo transfer. No need for any anesthetic, much like the insemination or a hycosi, ultrasound probe, push a little tube through the cervix, and we watch a little pixel of white light go into the lining, and then it's just hopes and dreams for about 11 days. Patients will get progesterone to support the pregnancy, and then it's a nervous wait until the pregnancy test. They don't need to do anything particularly special, just be sensible. If that pregnancy test is positive, great. We do the dating scan and then everything goes back to where it needs to be. If not successful, they can do a frozen embryo transfer cycle if there's spares that are left over. But if there's no embryos left, we still have to go back through that stimulation cycle rather than just doing a natural cycle, meaning without medications to put an embryo back. But that's all getting a bit too technical. It's important to remember that IVF has basically an improved monthly pregnancy chance, but not 100%. And it's completely age-related and ovarian reserve related. If you ever want to guess how effective IVF will be, it's basically one cycle using all the embryos is double the monthly pregnancy chance for someone's age. That's all you need to remember. It's really basic. So given those numbers, meaning that the best embryo in the world has about a 65% chance of working, it means that people will often have to do multiple cycles to achieve pregnancy. The risks, we won't go through them, but basically, and I'll answer the questions right at the end because we're almost there. The biggest risk is it takes over their life. It's a full-time job. You can see there's lots of blood tests and phone calls. And the other thing to let people know is that we end up with less than we start with. So you might have 15 follicles to begin with. Only 10 of them might grow big enough to collect. We might only get 9 eggs. Of that, only 4 fertilize. And then you might get 1 or 2 embryos at the end of that. And you look back and you go, well, hang on, I had 15 eggs. Why do I have only 2 embryos with a 35% success rate? It's the cruel funnel of this process that we have to go through. The less follicles you start with, the higher the chance of ending up with nothing. But if you start with one egg, in theory, and I've had a couple of patients like this, one egg goes all the way through, not just an embryo, but it ends up in a pregnancy as well. So the more we start with, the more we end up with usually. I won't talk about the other risks because that's more detailed for me. Here's practical tips. So you've decided that you want to refer someone for IVF. It's a mess. Everyone's doing billboards. Everyone's telling you what's good and what's not. I have no skin in the game. I just want you to know what's right. So I need you to know that most clinics all have similar success rates. This is public information available at any time via a website called Your IVF Success, which is basically done by the regulator. And so you'll be able to predict someone's success rate based on their age and factors. You also be able to do an egg freezing calculator. But you can see clinic by clinic in New South Wales what their success rates are compared to the average. It's important to note that costs vary much more than success rates. So going to an expensive place doesn't necessarily you're going to get a higher success rate because the difference is a few percentage points. But ultimately, IVF clinics get broken up into 3 providers. The first are premium providers, all the names that you know. High cost, more personalization, a lot more service and shiny bells and whistles. There's then the low cost providers, but they have less personalization, maybe a few more compromises on the nice to haves, but generally speaking, their success rates are very similar, if not more in some cases, than the other expensive places. But there are some obviously statistical anomalies there. They also often have less services. So if someone wants to test their embryos, some of the low-cost clinics don't provide that. And the public hospital, of course, as well. To put this into perspective, the out-of-pocket cost for a premium IVF cycle might now be $8,000 to $9,000 for some people. At a low-cost provider place, the out-of-pocket cost is about $1,000, with a small percentage point success rate difference. Just to let you know. And then if you want to get started, GP referrals always welcome to the relevant fertility specialist that you trust the most. And you will often get regular cycle updates and then obviously a referral back once that person is pregnant. And that's it. I think we made some time. I'm going to answer the questions as I go through, but feel free to please put questions in as we go along. And thank you for attending. Why does IVF still fail if controlling all the parameters as well? Because all we're dealing with is the embryonic side of pregnancy. So after that, implantation, the immune environment, stress, genetics, all sorts of stuff of the woman carrying the pregnancy, we don't have full visibility of knowledge over that anymore. So even premium embryos only have about a 65% chance because of those unknowns. Is there a limit on number of embryos stored? There's no formal limit, but we wouldn't do cycles for no reason if there's already embryos stored in. In terms of egg freezing, so most of these providers, in fact, all of them, also provide egg freezing. It's important to know that your costs of egg freezing vary widely as well, because if it's done as social egg freezing, not a term that I like, but one not indicated by medicine, they pay out of pocket and there's no Medicare coverage. And so a lot of the benefit in those low-cost providers is that they're doing it for Medicare rebate. And once that rebate goes, if the egg freezing is social, there's a less of a distance in the cost between them and the premium providers. Where I work at Connect IVF, really high success rates, but we work on a low-cost model, and I'm very proud of the quality that the lab and the people who founded the company are doing. So that's why I work there. Just not a spruik for it. Take a patient anywhere. There's lots of good doctors out there, but that's what I'm familiar with at the moment. Any other questions you'd like to ask? What I'll do, so chat. Yeah, so feel free to, I'm based in the CBD, but can do telehealth. So feel free to reach out if you have any questions or want any advice. No referral needed, just happy to chat. But thank you for attending. Really appreciate it.
Thank you, James. It was a brilliant presentation and a very engaged audience, which was fantastic. And thank you for answering the question.
No worries at all.
Great presentation, lots of feedback from the attendees. So thanks, Dr. Brown and Tali, for organising tonight's session.